Hello, friends. For today's lecture, we are going to look at Genito Urinary Fistula, and Modrik's is still the presenter that's going to give the information, and try hard to share the link with your medical colleagues so that they can get information for refreshing the mind, and also the scholars so that they can get some information from here. Thank you. So as for today, we are going to look at the following objectives. And here we go. We are going to define a genitourinary fistula. We shall look at the brief pathophysiology, the classification, shall look at the etiology of genitourinary fistula, shall also look at the clinical presentation, the diagnosis, and also the quick history that one can get from a fistula patient. So once we fulfill all those objectives, we shall call it our video for today. So when you talk about genitourinary fistula, the word genito refers to the uterus, cervix, and vagina. And when you talk about urinary, we refer to ureters, bladder, and urethra. And a fistula, it is an abnormal communication, an abnormal orifice that appears. So when we talk about genitourinary fistula, this refers to abnormal communication between the urinary and the genital systems. These two systems get to connect by an abnormal hole, which you call a fistula. And when you talk about this genitourinary fistula, we are saying the commonest of all, as you're going to see, is the vescovaginal fistula. Is the commonest among all other fistulas that you're going to look at. So what is the pathophysiology, or how does a fistula come into place? How does it start to form? And you are saying this is common in people who get obstructed labor. So in obstructed labor, the bladder and the vaginal walls are compressed between the fetal head and the pubis species for a long time. We are saying if a mother gets to have a prolonged labor, the bladder and the vaginal walls are going to be compressed by the presenting part. And this, in case you are looking at the fetal head or the cephalic presentation, and there is pressure that is exerted on this bladder and the vagina and the species pubis for a long time. Because of this results into ischemia, and that is cut off of blood supply to the tissues. And once blood supply has been cut off from the tissues, then there is ischemic necrosis. The tissue starts to die off. And once they start to die off, a slough is formed. A dead tissue is formed. And eventually, this dead tissue is going to be removed by the body so that the body can take it off. And in so doing, a fistula is formed. That's a brief pathophysiology, how a fistula comes to be in place. Classification of fistula. So we have several classes of fistula. And here we shall be comparing the urinary, as we said, and also the genitals. A fistula that appears between the vagina and the ureters, that one we call it ureterovaginal fistula. The one that appears between the vagina and bladder, we call it vescovaginal fistula, and this is the commonest. The fistula that appears between the vagina and the urethra, we call it ureterovaginal fistula. Then there is a fistula which appears between the bladder, ureters, and the vagina. This one is called vescoureterovaginal fistula. Vescoureterovaginal fistula, for it appears between the bladder, ureters, and the vagina. Then we have another classification of fistula, the one that appears between the cervix and the ureters. We call it ureterocervical fistula. Then the one that appears between the cervix and the bladder, we call it vescocervical fistula. Then the fistula that appears between the cervix and the urethra, we call it ureterocervical fistula. Then we have another classification where we talk about a fistula between the uterus and the ureters. We call it uretero-uterine fistula. Then the fistula that appears between the uterus and the bladder is called vesico-ureteral fistula. Then there is no fistula that appears between the uterus and urethra. That one haven't been gotten. Those are the classification of fistula. We continue looking at the cause of fistula. The cause is unknown. So what we have here are like predisposing factors that can lead to a vesicovaginal fistula or any other fistula. One is congenital. Someone can be born with an abnormal communication between these two organs. Then we talk about obstetrical trauma. This is during operations, during obstetrical procedures. Someone can be traumatized and hence a fistula is formed. Then we talk of pelvic surgery. Any surgery, maybe it's open prostatectomy or any other surgery. Someone can end up get any other surgery in the pelvis. For example, it can be the mother is being operated, there's a cesarean section, maybe has an issue to do with the reproductive system, who can end up having a fistula, even if it is a episiotomy. Then we talk about ischemic, and that is cut off of blood supply. Then there is trauma or traumatic, as how it is on obstetrical fistulas, the same. Then we talk of instrumental vaginal delivery. In case they use instruments, they can end up traumatizing. Then abdominal operation, they can end up cutting the ureters and hence communication. We look at radiation therapy. These denature cells and they die off and a fistula will form. Malignancy, because of swelling, it causes ischemia as it compresses the organs. Then a foreign body, we talk of infection, talk of pelvic inflammation, then also Crohn's disease, which is the inflammatory bowel disease. Those are the causes of a fistula. So, as we say, the vesicovaginal fistula is the commonest. So these clinical presentations are linked to vesicovaginal fistula. So what is going to happen? One, there is continuous urine leakage from the vagina, and that is in the case there is vesicovaginal fistula, and this can be reported after recent operation or obstructed labor. Then there is ammoniac fluid smell. There is a smell of ammonia, and this is a smell of urine that will appear on this person who has a fistula. Then there is associated stool incontinence, that is in the case of a rectovaginal fistula. There is dermatitis. The dermis at the vulva level is inflamed because of always being wet by the urine. And those are some of the clinical presentations we are going to have in this person. Then how do we diagnose a fistula? One, take history, and it must talk about prolonged labor or any other issue like trauma, as I've seen in the causes. Then we do physical examination, and here we put the person in same position, and we use a speculum to check the presence of fistula. There is a dye test, which I'll explain furthermore. We can also do cystourethropy. We observe via the urethra up to the bladder and see whether there is an abnormal communication, voiding cystourethrogram. We put dye, or we tell someone to urinate, and we see where is urine exactly coming from, and also examination and anesthesia can also be done. Quick history that you can do for a fistula patient. One, we are saying, when did the problem start? Many of them, it starts after delivery, and sometimes they be having a baby. We can ask the mode of delivery, whether it was cesarean or instrumental or spontaneous vaginal delivery. We can talk about the baby. Was the baby big, or the baby was having a big head, more weight? We talk about operation. Was the mother operated, or was there any tear? We look at the urine leakage. Leaking all the time. Does she pass any urine? We look at what it means if she leaks or pass urine, like in the case of uteric fistula or very small fistulas. Another thing we shall look at the LNMP. And why do we look at this? Because we want to avoid operation. Sometimes the LNMP was a bit late, and we miscounted the EDD, and we find you're operating someone who could have delivered. Then we talk about the issue of stool and flatus leakage. Is it often? Will it not? Most times the patient will not complain of this flatus and stool, so we need to ask them. So that is the quick history that we can do for someone who has a fistula. Thank you for listening. Just this is our video. You can follow it and share the channel. Share the link with your colleagues. Thank you so much.